for joining me today. I'm super thrilled to not only have this opportunity for you all, but to welcome our guest speaker. So we're going to go ahead and get started with a couple housekeeping things. Just so you all know, Pre-Health Shadowing is a virtual platform for like-minded students and professionals to connect and learn a little bit more about the various health fields before committing to a career in this wonderful journey. So Pre-Health Shadowing is open to anybody who's interested in joining. And so it's my favorite part to kind of see where everybody is zooming from. So go ahead and drop in the chat where you're calling us from today. Wow, welcome everybody. I see people from everywhere. That's awesome. Great, welcome. All right, just an update for you all. We now have closed captioning for all of our live sessions to accommodate students with hearing disabilities. So Pre-Health Shadowing is striving to create flexible and accessible opportunities, accessible in that we are open to anyone who is interested and anyone who has the dream of being a doctor can achieve their goals, and we are hoping to make that possible. Really quickly, please mute yourselves if you are not already muted. Thank you. If you are interested in getting published, I have some good news for you. We are taking submissions. You can submit an article, a reflection of a specific shadowing session, a review of either a shadowing session or our program as a whole, as well as success stories. So you can have the opportunity to get published. This is not only great to get your name out there, but also for any application, CVs, and resumes. If you're looking to get, to stand out, this is a great opportunity for you to really put some great insight out there. So you can find this on our website, www.prehealthshadowing.com/blog submissions. For everybody that is joining us today, I would welcome you to please pull out your phones and scan this QR code. This will take you to the Pre-Health Shadowing donation page. Pre-Health Shadowing is a student-based, student-led nonprofit organization that survives only off of the support from the community. And so I am super excited to welcome you guys all and provide this opportunity for you. Please help us by keeping Pre-Health Shadowing alive and to keep our goals of making accessible opportunities for people around the world. Thank you all. We are introducing a new program for Pre-Health Shadowing, and this is a high school training for Pre-Health Shadowing program. And so if you are in high school and you're interested in joining our team, this is a wonderful opportunity, not only to connect with other high schoolers that are interested in health, both nationally and internationally, but also to gain some leadership skills and things that are going to serve you really well in your future endeavors. If you guys are interested in gaining a mentor, Pre-Health Shadowing is hosting a mentorship networking weekend. This is the opportunity to meet with different professionals and kind of get to learn a little bit more about what they do and how they can help you in your journey. And so this is a 3-day event. This will take place on a Friday, Saturday, and Sunday in the month of February. And for each day of the event, you'll have the opportunity to meet with up to 2 different established professionals for a total of 6 professionals if you would like to join all 3 days. You can gain connections not only with potential mentors, but with like-minded students who can be a resource for you in the future. You get the chance to work on your interview and speaking skills as you get to communicate with the professional and try to gain that great connection. So if you're interested, how do I join this mentorship opportunity? This is how you do it. Super easy. You are going to download the materials from our Google Drive folder. You're going to sign up as a volunteer, and you're going to post all 3 pictures on your social media. What this is a bingo board fundraiser to help support Pre-Health Shadowing and make this event possible. Each bingo board has 16 squares for a total of $136. Once you submit your final bingo board, you will gain an invitation to RSVP for our event. If you guys have any questions about this, I'm more than happy to answer them. You can email us at fundraising@prehealthshadowing.com. Don't forget, once you fill up your board, you must submit it to pre-health shadowing. There's a form to fill out. Once you do this, you will get guaranteed invitation to our event. If you are interested in helping out, pre-health shadowing does have virtual volunteering hours. It's very easy, very flexible. If you're interested, check it out on our website, www.prehealthshadowing.com/volunteer. There's a bunch of different things going on. This week, we are transitioning our volunteers to work on their own projects. So if you are interested in potentially leading a group of other volunteers, you should definitely sign up for this. Great hands-on projects, leadership skills, professional development, all from the comfort of your home. If you're joining us for our live session today, go ahead and post us on your social media for a chance to get reposted onto our official page. Be sure to tag us at pre-health shadowing, and see you then. So with pre-health shadowing, students can take a post-shadowing assessment and receive a certificate that verifies your hours for today. So I encourage you all to take good notes and ask some great questions for our professional. At any time during this presentation, feel free to drop any questions or comments in the chat, and we will be sure to ask them during the Q&A portion of today's session. And without further ado, I would like to welcome to you our speaker for today. Welcome. Thank you for joining us.
Thank you so much for having me. Hello, everyone. This is impressive. Wow, 300 participants. So I'm really excited to share my journey with you guys and kind of talk you through how I got to where I am and some advice and tips that I have for you guys. I wanted to start out with a few of the poll questions just to get an idea of where everybody is in their training. So if you want to do that now, Nina.
Alrighty, so I have just launched it. There are 3 questions about you. So we will leave this open for about 30 seconds. Awesome. All right, go ahead and put in your vote if you haven't yet. We currently have 85% voted, and I'm gonna go ahead and close it. Alrighty. So just take a look around the room, take a look around the Zoom room and see who you are sharing this Zoom space with. Alrighty.
Perfect, thank you. So let's get started. Can everybody see my presentation?
No, not yet.
Oh, hold on.
Awesome.
Okay. Now?
Yep, good to go.
Perfect. So a little bit about me. I grew up in Atlanta, Georgia. I went to Georgia Institute of Technology for undergrad, and at the time I majored in biomedical engineering. And for me, I chose that major because at the time, applying engineering solutions to medical problems sounded very interesting to me. And it was a very interesting major for sure. But after grueling classes in thermodynamics and mechanical engineering, it was not so kind to my GPA. From there, I went to medical school at Philadelphia College of Osteopathic Medicine, and then transitioned to Drexel for internal medicine residency and fellowship at Temple. So a little bit about my residency fellowship. I started out residency at Drexel, and then I started fellowship there. And about 3 months into my fellowship, due to corporate greed, Drexel which shut down its residency and fellowship program. So there's about 580 of us that were displaced from our residencies and fellowships. So this was a pretty tough time. We were, battling in the courts to figure out where we were going to go and find our funding, et cetera, et cetera. So I will say this, I know this is a really tough time for you guys. You're in medical school, you can't rotate in person with people, you can't make the relationships that you need to make to get into med school and have letters and things like that. But you will be stronger for it once all of this passes. So I will say just hang in there and everything will definitely work out. But from there, I decided that I was interested in obesity and nutrition. So I did an obesity fellowship and I'm board certified in obesity. And then I will be doing a nutrition fellowship as well. But right now, I'm finishing up my 3rd year of GI, and then next year I'll do my nutrition fellowship. Aside from that, we're right now in the process of finding a job. And after 10 years of training, we are so excited for it. I will be accepting a position in an academic place in the Northeast for Director of Nutrition and Medical Obesity. So with that being said, a couple of tips I wanted to start off with in the beginning before I kind of go into GI itself is when you're applying for medical school, there's a couple things that you have to do, and these are probably things that you've seen online when you Google how to get into medical school. So I wanted to talk about each one just a little bit. When it comes to choosing your major, I see that most of your biology, and that's completely fine. That's what a lot of people who go into medical school do. All that's important is that you do your prerequisites in biology. Otherwise, choose something that you're truly interested in. If you like public policy, business, economics, it really doesn't matter. You just have to make sure that you excel in those classes. Your scores and your grades, your score on the MCAT and the grades really matter when it comes to going into medical school. But if you didn't do well in either of those things, it's okay. Make sure that you address it on your personal statement, that despite whatever it was that didn't come out to whatever you wanted, you still want to be a doctor, and why. When you're choosing your activities, you want to make sure that you stand out. Don't just do something for participation. Try to do more than a passive, be more than a passive participant. So for example, take a leadership role, excel in whatever activities that you're interested in. I think this is a really great organization to get involved in. It's at a time when students really need this type of program. When it comes to research, some people have it, some people don't. I think that it can set you apart having a little bit of research. When I was at Georgia Tech, I did bench research at Georgia Tech and some clinical projects while I was at Emory. I think a lot of students have a hard time finding a project. And I think the best way, or the way I did it, was really just cold emailing professors. So you go on your college website, or if you want to go to another university and do it there, you go to their website, you find professors, you look at what research they're doing, it's all on their website. You find something that you're interested in, and then you just cold email that person. Eventually somebody will respond and somebody will say yes. And that's what I did. And through that, I was able to get a book chapter and a paper out of it. So, things will come out of cold emailing. And you guys are at a fortunate time where social media is so, makes people accessible. So instead of guessing people's email addresses, you can always message them on Twitter or Instagram, and people are more than willing to help people out. When you are sending an email, I would recommend that you express your interest, what your experience in research is, and then attach your CV so they can contact you. So make sure that you're timely, you show interest, you meet deadlines, and you make your preceptor's life easier. One of the most important lessons that I learned, when I was in college and kind of going forward, is physicians are busy, and unfortunately, emails get missed, messages get missed, and you guys need something, so if they don't respond the first time, it's more than okay to send another email reminder or drop by their office. Be persistent without being annoying. You have to find that balance. And all of this is to say is going to lead to good, strong letters of recommendation, right? No one is expecting that you're going to, be on some amazing project that creates huge change. But you establish relationships where people can understand your work ethic, and they can write you a really strong letter of recommendation, because connections go very far in the medical world. That being said, I think the most important thing is to talk to as many people as you can. This is a very long journey, and there are some tough days that make you wonder, what did I go in? Am I sure that I want to be whatever I'm going to be? And then there's a lot of rewarding days as well. So make sure that you have a compelling reason for going into medical school, and you find that reason by working with people, talking to people, and really making sure that this is what you want to go, want to go into. Okay, so pathways to medicine. If you didn't get into medical school, or you're interested in an alternative pathway, there are other paths to medicine other than going to MD school. One of them is going to a DO school, so a doctor of osteopathy. There's about 11% of the physician workforce currently consists of DOs. Essentially, these are physicians that have the same medical school curriculum, requiring similar board certification, with additional training in something we call OMM, or osteopathic manipulative medicine. So it's essentially, it's evidence-based. It's a hands-on approach to diagnosing, treating, and preventing illnesses and disease. So one of the big things that OMM works on is musculoskeletal issues. So if you have muscle strains, sprains, things like that, it uses various techniques to help treat those conditions. But it can also be used for other things. So this is one that we use for constipation. So there's a lot of things that you can do with OMM. Other things that you can do are post-bac programs. Essentially, these are one-year programs between undergrad and med school to support the transition into med school, or to enhance an applicant's competitiveness. So they can address whatever thing that you feel like you're lacking. The AAMC has a great list, and I put a link here, of various post-bac programs. And a lot of these programs will kind of, if you do well, they'll take a certain proportion of the patients into their medical school. But if this happens and you didn't get into med school, feel free to reach out to me. I know my email will be at the end, and we can kind of talk more about what the next steps would be. But there's a lot of options. Okay, so I'm a GI fellow, gastroenterology fellow. My path to medicine, my path to GI, I did 4 years of high school, 4 years of college, 4 years of medical school, 3 years of internal medicine residency, and then 3 years of GI fellowship. And after that, there are additional fellowships that you can do in GI. There's hepatology, which is where you focus on the liver, advanced gastroenterology, where you focus on the biliary tree and the pancreas, motility, which focuses on the gut movement, so disorders of movement that affect the gut, inflammatory bowel disease, nutrition, and obesity. So why did I choose GI? And you guys will see this. I know I talked to a few people that had kind of already decided their subspecialties that they were interested in. A lot of choosing a specialty comes down to your experiences, your mentors, and your personal history as well. So this is why rotations during medical school are so important, because you spend time exploring all the different options in medicine, and you narrow it down based on the experiences you have, the positive experiences you have. So for me, going through medical school, I really enjoyed working with my hands, but I also really liked having medical challenges and working directly with patients. And there's multiple specialties that combine the two. Also, I just really love the variety that GI offers. There's so many things that we do. And so I'm just going to go into that a little bit. So we take care of mouth to butt. So the esophagus, the stomach, small intestine, large intestines, the liver, the biliary tree, which is the plumbing that empties out the liver and gallbladder and pancreas, the gallbladder, the pancreas. We're also very this is new, but we're very involved in obesity management. This is kind of the, how GI is currently the forefront of innovation. We're really encroaching upon some of the minimally invasive ways that surgery used to do before. So here, one of the things that we do is we suture up the stomach and create a smaller stomach so people get full quicker. And this is a minimally invasive way compared to what the standard of care is, which is surgically creating the similar anatomy. We can also place various balloons that cause you to feel more full and decrease how much you eat. So all of this can lead to weight loss. And there's a lot of other tools and cool techniques that we're doing now. One of the big things that we do is we treat bleeding throughout the GI tract. So here you can see, this is under this blood, there would be an ulcer and there's a vessel that's shooting out blood. And we can look at the bleeding from the small bowel using this capsule. It's a pill that you swallow. It takes about 10,000 pictures of your small intestines and lets us know how to access and what to use to access bleeding in the small intestines. We're also very pivotal in diagnosing, preventing, and treating even colon cancer. One of the other things that we do is we do internal ultrasounds. So patients who have masses that have been seen close to the GI tract or in the GI tract, we can go in, put an ultrasound in, look at it and sample it to see and diagnose cancers. We do ERCPs, which evaluates and treats diseases of the bile tree and pancreas. Like I said before, we also work with the gut motility, and that's how the esophagus, stomach, small bowel, large intestines, how effectively they move, and disorders when they don't move effectively. And we also work with nutrition. So patients that require special tubes for feeding because for whatever reason they can't take adequate amounts of food through their mouth, we provide for additional types of nutrition. So there's a lot of variety in gastroenterology, and we're also at the forefront of a lot of cool innovation right now. So I'm a GI fellow, and most of my, I do a lot of inpatient, outpatient work. When I'm on the inpatient side, we rotate through hepatology, which is liver stuff. We do advanced GI, which is pancreas, bile tree, and gallbladder. And then we do general GI, which is a lot of bleeding and constipation, diarrhea, a lot of mix of things there. And so we get in super early. We see all the new consults and follow-ups by like 7:30. We start doing inpatient procedures, kind of go through the afternoon, and then we round on the patients and do any emergent cases that come up. We also work in the outpatient clinics, seeing various types of patients. We also do outpatient procedures. So this is where we do most of the screening colonoscopies to look for colon cancer. As a fellow, we are involved in teaching medical students, residents, lower year fellows, performing research in aspects that we're interested in. A lot of my research is in obesity and nutrition. I also enjoy medical writing, so I do social media education and write for our local paper. So I did want to talk about a few cases. Now, this is less so for you guys to learn about gastroenterology and more to understand kind of what we do. So this is a very common reason that we see that we're called in the hospital. And so I'm just going to go through a case. So this is a 50-year-old patient with past medical osteoarthritis on ibuprofen who presents with black stools, lightheadedness, and dizziness. Vitals show a heart rate of 110 and a blood pressure of 90/60. So that's tachycardic and hypotensive. Hemoglobin is 6.8, so with a baseline of 14. So it's a significant drop from what they used to be with iron deficiency anemia. So one of the most important things that we do in GI is bleeding. So I have a poll question here, but we have to look at the stool to get an idea of what color it is. And the color lets us know where they could be bleeding from and where we need to look. So it becomes really important that we look at people's stool. So we do a lot of rectal exams. And I do encourage when you're a medical student, a resident, to make sure that you do these exams whenever you get a patient that's bleeding. So I know there's a lot of pediatric people that are interested in peds and medicine as well. So this will be kind of a regular thing that you see, is a very common patient complaint. So here what you're seeing is black tarry stool, and that's blood, and that usually tells us it's an upper GI source. Okay, so what would you do next? I think there's a poll question here. So would you perform an endoscopy, which is a camera test where we would go in and take a look at the stomach, the esophagus, and small intestine? Would you give intravenous fluids and blood products, or would you start the patient on more ibuprofen? And you can guess. It's
Alrighty, we have about 75%, 80%. All right, when we hit 85, I'm gonna end it. Alrighty, and I'm gonna share the results. Looks pretty split.
Yeah, no, that's good. So what we would recommend doing next is supportive care. So first you want to make sure that you put the patient in ICU because these patients can deteriorate very quickly. You want to make sure we resuscitate the patient. So the goal in resuscitating any patient is to make sure that we get their systolic blood pressure up and we have a hemoglobin of more than 7. And so this patient had less than 7, it was 6.8. So we would transfuse them. And the reason we do this is patients that don't have an adequate blood supply or fluid supply or adequate volume in their blood vessels, their mortality is higher. So we want to make sure before we rush in and do any procedures that we kind of tank them up. The other thing we would do is start a medication called pantoprazole. This is an acid blocking agent. And what it does is that it ensures that the pH of the stomach is high enough that a blood clot can form and kind of adhere to that spot. And ibuprofen is one of the reasons, a big reason why patients bleed. The use of over-the-counter pain medications like Advil, Motrin, Aleve, ibuprofen, they are not benign and one of the most common causes of GI bleeding. So here you can see an ulcer right here, and in it is a blood vessel right here, and it's shooting out blood. And this makes most people very nervous. You know, this is the situation where patients can deteriorate quickly. You'll see the blood just fill up the stomach. And so the way we treat this is we inject the site with epinephrine. It's a medication that causes constriction of the blood vessels and will slow down or stop the bleeding so we can actually take a look at the site. Then we have a couple of options for treatment, and you know, we could place clips and close the area where there's a blood vessel, or we can use heat therapy and kind of burn the vessel down and eventually so that it prevents further bleeding. So any of those options are possible that we could do. Okay, the second case I wanted to talk about is a 25-year-old with past medical history of schizophrenia presenting with dysphagia and odynophagia. And dysphagia is where food gets stuck when you're trying to swallow. And odynophagia is pain with swallowing. And the patient is able to tolerate her saliva. They get an x-ray in the emergency room. They see a metallic tip and a plastic casing in the stomach. So here's another poll question. What do you think the diagnosis could be? Perfect. Good. You guys nailed it. This is another very common reason for us to be called in GI, where you'll see patients swallow various objects. 20% of ingestions require some sort of intervention. In adults, intentional foreign body ingestion is usually seen in psychiatric illness, intellectual disability, patients with substance dependence, incarceration, or body packing. And there's certain locations where things get stuck. One of them is esophagus because of the narrow caliber. One of them is the pylorus, which is kind of the entryway, the exit from the stomach into the small intestines, and then the ileum, which is the exit point from the small intestine into the colon. So there's valves in these areas, and that's usually where things can get stuck and don't pass on. These patients often present, like I said, with trouble swallowing if it's in the esophagus, pain swallowing if it's in the esophagus. If things are in the stomach, they may not feel a whole lot unless it's completely blocking the exit, in which case you can imagine if you're blocking the exit, things build up behind it and then it comes right out. So the objects that we go in to remove are usually things that cause complete obstruction, things that are sharp, things that are greater than 6 centimeters, things that fail to pass through the GI tract, button batteries, or magnets. The only time we don't recommend going in is if you have drug packing, which we've seen. We've gone in before and seen packs of cocaine. And the concern there is if you were to grab it the wrong way or poke through it, then you release the drug and they get, it's a pretty large volume of drug that's released kind of directly into their body. So these patients could die. So that's the only time we do not encourage anybody to take those out. Okay, so these patients, we tell them not to eat anything. We put a tube down into their airway for breathing, for protection, just so that things don't drop into their airway as we fish stuff out. And then we go in with a camera test with endoscopy and retrieve the objects. So some of the crazier things they've taken out in the last year: belt buckle, part of someone's glasses, surgical scissors, razor blades, pencils, pens. These are the patients that come in every weekend at 2 a.m. in the morning, and you'll be fishing things out of their stomach. But it's definitely interesting because each type of object has its own challenges, but it's another kind of common reason that we're called in. And the third case I want to talk about is colon cancer. So this is a 60-year-old male with no past medical history, presenting with weight loss, rectal bleeding, and constipation. Hemoglobin of 7.1 with from a baseline of 14, so they're anemic. The iron is 4, saturation is 8%, Barometer of 10. That lets us know it's iron deficiency. So they're losing blood. You do a rectal exam because rectal exams are very, very important in GI, and it shows brown stool. That just lets us know the bleeding is intermittent. It's coming and going. So at the time you did a rectal exam, that patient wasn't bleeding. I think there's a poll question here too. Is there? Oh, you know what? I might have already answered this one. So what do you guys think the diagnosis is? This will just be a test to see if you guys are listening. Yep. Okay, perfect. So this person does have colon cancer. So one of the big things that we do in the GI department is we screen patients routinely for colon cancer. As per the guidelines, our GI guidelines, we start at 45 for African Americans, 50 for all other individuals. Although now the guidelines are changing, and probably will go to 45 for all patients, because the rate of colon cancer in that 45 to 50 range has increased significantly. And, a lot of the times the way we do colon cancer screening, the most common thing that patients get is a colonoscopy. And it's important when you're in medicine, no matter what area you're in, you'll be sending people to get colonoscopies. And the way we do that is the patient has to be on clear liquid. So if they can see through it, they can eat it or drink it. So Jello, broths, juices, teas, that kind of thing. Nothing red, nothing purple. And then they drink this gallon of Go Lightly, which clears them out, makes them poop, poop, poop like crazy. And it's part of the worst part of a colonoscopy is that. Then they come in and we do a camera test from their bottom. And we take a look for polyps, which are growths, different types of growths. And if we see any of those, we take them out. And patients are on a screening regimen or a surveillance regimen every so and so years based on what we find on the initial one. There are a lot of other ways to screen patients, and it's something that we discuss and can kind of decide what someone's going to do. And if we see someone with cancer, depending on the severity, how much it's spread, how deep it is into the tissue, either we can take it out ourselves and prevent them from having to get part of their colon removed, or if it's kind of spread through the various layers of the tract, GI tract and colon, then we'll have to send them to surgery and the cancer doctors as well. These are just a few cases of things that are very common that we deal with kind of on an everyday basis that I wanted to talk about. But there's a lot of interesting things in GI and a lot of innovation right now, like I said earlier. So it's a very fortunate time to be in medicine. I think for you guys, with the advent of social media, it makes people so much more accessible. Use those resources, talk to people, message as many people as you can to get advice. I'm always available. My email address is here, so feel free to message. Again, if I don't respond in a day or two, shoot me another email. I do not mind. Do you guys have any questions?
Thank you so much for this wonderful presentation. To get into the questions, the first question is, how has COVID affected patient relationships and everyday work for you and your specialty?
Yeah, it's actually a really unfortunate, telemedicine is great. I'm glad that we've started to incorporate that into our daily lives as physicians. But I think there's something that you really lose out on when you aren't seeing the patient. There's a lot to a physical exam, and the art of physical exam has been lost over time, but there's still a lot of things that you have to see in person. So when we're in liver clinic, we see these sick liver patients, and they need an abdominal exam to decide, hey, do they need to get fluid taken out of their belly? Are they confused? It's really hard to tell if someone's confused on the phone. So I think there's pros and cons to telemedicine, but there's a lot of instances where I'm on the phone with a patient and I really wish I could see them in person and examine them in person. So I think that over time, I'm hoping our clinics in general can kind of differentiate between who can be on the phone and who shouldn't be on the phone. I think it's really affected patient relationships in that way. It's hard to connect as well over the phone. The other thing I would say in GI is procedures. Because we're procedural based, we still see a lot of patients in person. We still scope everybody, every day. So we're still seeing a lot of people. And I think in that way, we're able to kind of maintain that connection. But I think the threshold to make someone get a procedure is much lower when I'm on the phone with someone than when I see them in person.
Interesting, thank you. The next question is, what anesthetics are commonly used when doing your procedures?
Yeah, so it really depends on where you practice in the country. Some areas do something called conscious sedation, where they give fentanyl and Versed, and that kind of, the patients aren't completely asleep, so they won't always remember, but they will communicate with you during the procedure. So if they're uncomfortable, they'll definitely let you know. They'll move more. So as a trainee, I think those patients are a little bit harder when you're learning to take out polyps and things like that. But the patients are less sedated, so overall, they wake up quicker. The recovery time after procedures is quicker. So there's pros and cons. At my hospital, we are max, so we do mostly propofol. These patients they don't remember anything, they don't react to anything, they are out. So it's, as a trainee, I think it's easier to train on those patients, but it really depends when you get into practice, where you're located, what they'll use for GI procedures. But overall, if you go into surgery or anything like that, you'll use mostly propofol.
So you talked a little bit about the various objects that you withdraw from your patient's stomachs. Can you talk about your most memorable case that you've had?
Yeah, there's two people I will talk about. One of them is a belt buckle. Um, it's a really unfortunate patient, who has significant psych disorder and is actually in an inpatient psych facility. So it's really challenging in that how she gets access to these, but we see her every week and she swallows something different every week. And we're never sure how she gets access to them, but I would say she's someone that every time you come in at 2 a.m, you're like, oh man, I have to come in. I'm so tired, blah, blah, blah. But you see her and you just feel so bad, it's a very difficult situation. And the other person I always remember is my razor blade guy. He does it as a party trick. He goes to bars and people pay him money for each razor blade. And he swallows like 10 a night. And most of the time, he has no issues, they pass through. And sometimes he has severe pain, so then he'll come in. And then we will fish out all of these razor blades. But I haven't seen him in a few months, so I'm kind of worried about him. But yeah, those two always stick out, and it always happens at like 2 a.m.
That's crazy. Thank you.
Ethical issue, at what point do you stop scoping these?
Definitely. Thank you. The next question is, what initially got you interested in GI and what experiences validated that choice for you?
Yeah, so for me in medical school, I did 2 months of GI and rotation wise, and I just had really great attendings that walked me through the procedures and took me from case to case and, seeing patients and discussions. And so I came into residency thinking maybe GI, and I did 2 months of liver and inpatient GI. And that's what really convinced me, you're able to offer someone instant improvement when it comes to inpatient GI. So you have a bleeder, you go in and scope them, you see something, you treat it, they stop, they go home, they feel better. So I really like that aspect, but I also like that you can follow these liver patients for weeks, months, years, and kind of grow with them as a clinician and treat them through all aspects of their liver disease and inflammatory bowel disease. So I like that you have that combination in GI. But it really comes down to who you work with and your experiences, because I will say the biggest reason I went into the field I did is because I had mentors in GI that really, took me under their wing and showed me the ropes and things like that. And I loved the field because I loved the passion they had for it. And I think I just grew to love it too. So it really depends on your experiences.
So you mentioned GI and its involvement in medical innovation. What do you hope to see in the future in your field? And what questions are still unanswered in gastroenterology?
Yeah, I think unanswered questions would be the microbiome, the gut microbiome. There's so much that we don't understand, and our technology isn't to the point where we can understand what's clinically relevant in the bacteria that we see and what's not clinically relevant. So right now we're getting a lot of data, big data, and we don't know what to make of it. So I think that is one area of GI that we're going to see a lot of progress in the next 5 years, because we truly believe that a lot of the diseases that we have, not just in GI, but in all of medicine, is affected by our gut microbiome and the things we eat. So I think that's one interesting aspect. And for me, the other interesting aspect is how can we manage obesity, with minimally invasive procedures. So right now, we send patients to surgery, bariatric surgery, and only 1% of patients that with obesity end up getting bariatric surgery. And it's a really low percentage. And there's a lot of reasons why that happens. So there's a huge need between medications and surgery of patients whose needs haven't been met. And so right now they're coming up with all kinds of ideas of what we can do endoscopically. So again, this, would be minimally invasive. You give them medications through their IV, they go to sleep. you put in a camera through their mouth, you do everything you need to do through the stomach, and they have no incisions, they have a very low recovery time, they go home very soon after the procedure. So there's a lot of benefits to it. And, it's curing diabetes, curing hypertension, it's making all of their other comorbid diseases go away. So it'll be interesting to see where that field goes.
That's very interesting. Thank you. The next question is, what undergraduate experience do you think prepared you the most for your career?
Prepared me the most. I would say just work ethic more, and like how to study, because what you'll find in medical school, or the biggest transition from undergrad to med school, is the volume of information that you have to take in at a very short period of time. People often compare it to a garden hose and having to drink from a garden hose that's turned up all the way, what medical school is like. And so I think it's really important when you're in college to kind of explore different types of studying techniques so that you can find out what really works for you, what makes you be able to learn a lot of information very quickly, so that you're ready for med school. I think that's really the most important thing in terms of how to get ready for med school. In terms of how to get into med school, I honestly think your scores and your GPA, like your MCAT score and your GPA, matters probably the most, more than anything.
Great, thank you so much. How has your identity played into your choice into going into medicine? Can you speak about your experiences as a member of a minority population and how that has affected your experiences both academically in graduate school and later on as a resident?
Yeah, I would say that I haven't ever felt like a minority in terms of my ethnicity, because my residency in med school were it was very diverse. In terms of gender related, I've always, women are definitely the minority in everywhere that I've been. So I think, sometimes it's hard to tell how you're being affected in terms of gender, because it's hard to see the inequalities until you know something different. But I haven't personally felt anything, any negative experiences because of my gender, at least where I've been. But I know I've heard a lot of horror stories, so we'll see. I mean, now that I'm in the job process, I see a lot more in terms of pay inequality, knowing what other starting salaries are for men versus what I've been offered. And so I think in terms of negotiating, that's where I'm noticing a difference. And so I'm trying to be, and I'm doing the same thing where I'm talking to everybody I can who is a female in the GI industries across. I'm using Twitter to kind of talk to people, and kind of getting understanding what they did when they were job hunting. How did they negotiate different jobs? How do they negotiate salary, benefits, and things like that? And it's really helpful now that I'm kind of negotiating, my contract and things like that. So I think this is the first time that I've noticed a difference.
Thank you. The next question is, how do you handle tough and uncomfortable interactions with patients?
Yes. I think that is where you'll see a lot of differences in the way they approach women versus men. You'll get called nurse, sweetie, which is fine. Not sweetie, but nurse is fine. There's nothing wrong with being a nurse, but we went to all this training. We should be respected for who we are, especially when you go and introduce yourself, like, I'm Dr. So-and-so. I think that it's important to establish boundaries when you go into a patient. I'm Dr. So-and-so, I'm your physician, because they don't always treat you the same way when you walk in with another male. There's been a lot of times I've walked in with my medical student and they think he's the doctor and I'm his medical student, just from, being a female versus a male. So I think that's something that you should establish with each patient as soon as you walk in. Hi, I'm Dr. So-and-so. I do feel like, you have to make sure that, you wear a white coat when you're seeing patients. I know right now no one's really wearing white coats in the hospital, but, there'll be a time in the future and the past where it'll be I'm hoping, back to normal. Or at least an ID badge that says physician, when you get to that part of your life, that shows who you are and what your credentials are, nice and large, so that patients can read it. In terms of difficult conversations for diagnoses, I think it's something that you get with time. I would say never shy away from having a difficult conversation, because every experience is a learning experience, and you'll be delivering a good amount of bad news while you're in your training and as a profession, no matter what, and just what field you go into, you're going to be telling people things that they don't want to hear. So I think it's important to acknowledge other people's feelings, listen to what they have to say. At the same time, be very clear and precise about the diagnosis. You'll find a lot of times that patients won't remember the conversations you had with them. So unfortunately, you'll have to deliver the same bad news multiple times, which is practice for you as well. So I think you'll get better with time. It's just a practice thing. Everyone has a hard time the first time they tell someone they have cancer or things like that, but you'll get better and better delivering that kind of difficult news.
So Emma in the chat just asked a question pertaining to the first poll that went out, asking if we were involved in medicine over social media, and a majority of our students today said no. How do you suggest we better participate, network, or promote education on those platforms?
Absolutely. So I think it's a really great idea to get involved on social media. I think more and more physicians, particularly on Twitter, they use it more in a professional setting to engage and to network, to share research, to exchange ideas, to talk about different patients, HIPAA compliant wise. So I think if you're interested in getting involved, definitely start with making a Twitter account. Follow various accounts based on the field you want to go into, what your interests are, other students of your same kind of time frame in the pathway, so you can understand what other people are doing and the experiences that they're having. I also find that you can find a lot of opportunities on Twitter and Instagram, whether there's different fellowships that you had never heard of before. It really makes the world smaller in that way, and that you're learning about different experiences. I would say if you're going to get involved, there's a lot of websites and things like that on how to be professional on social media. Just remember that program directors are on there, program coordinators are on there, various fellows, residents, students are on there. So it's super, super important that if you're going to have an account, a medical account, or you're going to be interacting with other physicians, that you keep it very professional. Don't put down your programs or other people. Be respectful to the people you're interacting with, things like that. So definitely there's do's and don'ts of social media that I think that you should read before you start that process, but I highly recommend it. I think it's a great platform to get advice, essentially. But start with Twitter. That's where a lot of physicians, or most of the physicians, are right now. There is a good number on Instagram as well that do a lot of social media education. I'm on there as well, and I like that in terms of interacting with other professionals in more of a fun way. Use videos and things like that to interact with people. It's still professional, but it's you're interacting with kind of similar-minded people, so you can use a little bit more fun teaching methods and things like that on Instagram than on Twitter. I would say it's very more professional.
Thank you. And I definitely encourage everyone to go follow your Instagram at DigestiveDoc and at Pre-Health Shadowing. Shameless plug. So the next question is, can you describe your relationships with PAs and NPs?
Yeah, absolutely. So in GI, we have 2 PAs, and they, kind of do the same thing as I do, except they don't scope. So they're in the outpatient setting. They see clinic patients from 8 to 5. Our interaction in terms of patients is sometimes, we'll send each other patients, but otherwise, professionally, we kind of operate very similarly. and that they're seeing patients, I'm seeing patients. And, you know, they they see patients by themselves, and if they have any questions, then they'll, you know, interact with, there's usually an attending physician that oversees the fellow and the PA. They'll ask them, but overall we have a pretty good relationship. I think that you'll find that most offices going forward will employ a PA or a nurse practitioner to kind of help with the volume, because everyone is really backed up from COVID right now, and there's tons of patients waiting to get into the clinic. So there's a lot of volume, and so we just need more providers. So there's a lot of PAs and NPs in every clinic right now.
What are some lesser known gastrointestinal diseases that you feel need more emphasis?
I would say in GI, EOE, eosinophilic esophagitis, celiac disease, or maybe that's not lesser known now, it's very popular. But EOE is eosinophilic esophagitis, where you see patients who have inflammatory cells that kind of occupy the esophagus and cause food to get stuck. If you'll eat a piece of chicken, it'll get stuck, and then it's a cause for you to come to the emergency room. We see those patients and we're digging out a lot of stuff, and patients are very surprised that they have this diagnosis. They hadn't heard of it before. So that's one of them. I'd say the other thing is NSAID use. People are, you know, use these over-the-counter pain medications without realizing the risk of bleeding. So Advil, Motrin, Aleve, naproxen, they all seem like benign medications. We can access them so easily in the office, but we see so many patients bleeding out from using these medications. So, you know, it's definitely something to keep in mind, that anything in for a few days or maybe a week or two is okay, but long-term use of these medications causes bleeding. Don't use them.
Interesting, thank you. The next question is, how would you say having a DO degree has been advantageous for your work in GI?
I would say in GI, I don't use it on a daily basis because it's a lot of musculoskeletal. There are other types of techniques that you can use, but I think visceral or organ related DO techniques are less utilized in our clinic. So if you're going into orthopedics or PMMR or those type of specialties, you'll be using OMM or osteopathic manipulative medicine more. You don't use it as much in GI, at least. There are a few techniques that I'll use for constipation, especially in bedbound patients, that you can use that I find helpful. But otherwise, I'm not using a whole lot of OMM at this point.
What is your understanding on the connection between psychological health and food sensitivities?
Yeah, that's a really good question. So food sensitivities, I would say in terms of, so there's a concept called leaky gut. And essentially the idea behind that is there's a disconnect between the mind-gut axis. And there's an idea that this disconnect leads to the cells leaking into the gut, to kind of be very basic about it. So there is a lot of ideas and theories right now currently floating in GI that, you know, stress, anxiety, various kind of psychiatric issues, depression, things like that, can really affect your GI tract. And they're still trying to understand more about it. But right now, the idea is that, you know, when you're managing these patients, that it's a multidisciplinary kind of approach. You should send them to a nutritionist or a registered dietitian. There should be a psychologist, and then GI as well. And that multidisciplinary kind of way of managing patients helps them actually feel better, rather than just kind of trying to see what medications you could throw at them. A lot of the symptoms that they'll have is bloating, pain, after eating certain things. And you'll see there's a dietary connection. When you go in with various tests, they're all negative. So right now we don't have a great way of definitively saying, okay, this is what's going on. But usually we have some criteria. We say, okay, well, this test, all these tests are negative. they have these symptoms, and they have all of these other stressors going on in their lives, then we can kind of diagnose it from there.
Interesting, thank you. The next question is, as a fellow, can you describe your work-life balance?
Yeah, I would say as a first and second year fellow, it is very busy. The program that I'm at now, you do call every 4 days, and then you're on one weekend a month. And those days are very, very busy. And so you're not really doing a whole lot when you're not at work. You're pretty much just vegetating on the couch, waiting for your next phone call to go back in. But as a third year, things do lighten up. You do see the light at the end of the tunnel. You have a lot of weekends off, and you're able to kind of pick up your passions and interests outside of medicine, and work on your own mental health a little bit. So fellowship is going to be hard, especially the first year, and then things slowly start to get better. But I think it's important to remember that when you're an attending, based on the lifestyle that you want, you can choose your job. And every specialty allows you to find a job that meets how much you want to work and what kind of lifestyle you want to live outside the hospital. So it's really important that you kind of figure out what you want, what you need to keep you sane. And so I think that's really important. I would say if you go into a specialty where you do a lot of overnight calls, the lifestyle there is going to be a little bit harder. GI is one of those, but at least you can take those calls from home. OBGYN, surgery, a lot of those are in-house calls. So, there's certain specialties where you have to do these overnight calls where you have to go in for things, or you're already at the hospital for things. I think those specialties, can have a little bit more of a challenging work-life balance, but you can always find a job that fits the schedule that you want. But as a fellow and a resident, the first couple of years are going to be tough. You're going to be working a lot of weekends, and the weekends that you have off, you're pretty much just catching up on sleep, laundry, food, cooking, stuff like that. So, but it's definitely possible to have a life and travel and do things like that. At least before COVID, I tried to make sure I went out of the country 2 times a year and tried to do something fun 2 weekends a month. So it's definitely possible, even if you have to sacrifice a little bit of sleep here and there. But whatever you need for your mental health, you're able to get it done.
Great, thank you so much. How often do you collaborate with doctors in other specialties?
Yeah, so I think nowadays the idea of multidisciplinary care has really taken off. So you'll find that no matter what specialty you go into, you're going to collaborate with other people, because people have finally realized that one problem isn't just one problem. There's a lot of things contributing to it. And you need a lot of doctors to work together to kind of figure out what it is and treat what they have. So one of the things I always say is, for example, you have Crohn's disease. You need a nutritionist, you need a surgeon, you need a gastroenterologist. You need all of these people kind of working together so that the patient gets the best care. And everyone's kind of talking to each other and has these conferences and presents challenging patients. So you'll find that no matter where you go for residency and fellowship, there's going to be these multidisciplinary conferences where people discuss cases and everybody kind of weighs in from different specialties, and you make a decision together in the best interest of the patient. And so you'll be interacting with all kinds of physicians in the hospital. If you have a cancer patient, you'll present them at a multidisciplinary session where there's surgery and oncology and interventional radiology and a GI. And so that's where medicine is moving towards now. And I think that's really great, because before we all used to kind of be in our own bubbles and do our own thing without considering that, there's a lot of players that need to come together to provide the best care.
Definitely. Thank you. The next question is, as a physician, what would you tell your college self as advice?
I would say enjoy the time that you have. Because I think that when you're going through the process, you're so concerned about the next step. You're working on all of these things. Your to-do lists are so long. Just make sure you're having fun and taking time for yourself at every step of the way. You will get into med school. You will become a doctor. If that's what you want to do, it will happen for sure. So make sure that in that process, you're taking time for yourself, you're doing the things that you still love to do, whether that's about medicine or not about medicine. I think that's the most important thing, because you'll become exactly what you want to become. It will happen.
Thank you so much. That actually just made me feel so much better about my life. Why did you choose the DO path over the MD route?
Yeah. So for me, when I was applying for medical school, I'm gonna be honest, my GPA was okay. My MCAT scores were good. All my other activities were good. So, I was concerned, whether I was going to get into what. So I applied to MD schools, I applied to DO schools, I applied to post-bac programs, and I applied to foreign, like the Caribbean med schools. And based on what I got back, I chose what I thought would be the best for me. And so when I was going through the process of where you guys are now, I rotated at various, I went to MD schools, I went to, volunteered with different doctors. I went to DO schools and looked at, went to their OMM clinics to see how that ran. And I really liked that hands-on approach, that extra class where you're kind of working with the musculoskeletal system and kind of really understanding the body mechanics. So I decided to go that route rather than going to post-bac and waiting a year to apply again or going to the Caribbean. At the time, I felt like that was the best option or opportunity for me.
Definitely. Thank you. The next question is, when did you take the MCAT? When would you recommend practicing for it? And what study tips do you recommend? Sorry, fully loaded question.
So I took the MCAT, I want to say right after my junior, like the summer between my second and third year of college. And I used one of the, it's been a long time, but I went to one of the Princeton review courses just at the very end. And I know I use a lot of resources. It's just been a long time, but I'm trying to remember. I will find out what I did. It's been a long time, but I did use one of the Princeton review courses and I found it to be very helpful. I was happy with my score when I got it back. It was a long time ago, so it was when there was only 2 digits. From my understanding, it has changed. The formatting has changed quite a bit. The scoring system has changed quite a bit since then. I think they added on another section. So it's been a long time. So I don't know what the exam is like now, but I went through a course. I just, I studied on my own for a month, and then I went to the course for about a couple weeks, I think. And then I took it like maybe 2 or 3 weeks after that. So I might've taken it in August of 2013. Yeah.
Definitely. Thank you so much for answering that. I know that the MCAT has changed a lot, and even more so now that COVID's happening. So for everybody who's taking it upcoming, be sure to check the website, the official website, to see what's changed. But our next question is, what type of research have you participated in, and how did you decide on the topics?
Yeah, so when I was in undergrad, for me, the topics, when you're just starting out, it's hard to tell what you're interested in. And so I took kind of the first project at the time that I was offered, and it was bench research. I was doing, looking at viral infections in monkeys at, using PCR and things like that. And I didn't find bench research interesting at all. And I knew that for sure. I mean, I continued it through undergrad, and then after that, I decided I wanted to do something clinical. So I cold emailed a bunch of physicians in the GI department, just randomly. At that time, I had no idea I wanted to do GI. And, got in touch with 2 gastroenterologists and started getting involved in transplant research. And I found that to be really interesting. And I still at the time had no idea I wanted to be a gastroenterologist. So it just happened to be random, and I found it super interesting and kind of continued with it through medical school. And, eventually that led to papers and presentations and things like that. So it's hard to tell when you're starting out what you like and what you don't like. I know some of you have kind of already mentioned that you know what fields you want to go into. So that's a good place to start if you know that you want to do pediatrics. But when you're an undergrad, you may not always have the opportunity at your own institution to do something with what you're interested in. So finding what's available is also important, but I think if you just cold email and see what comes back and then pick something that you're interested in through there, slowly you'll meet people, you'll understand their line of work, and then understand what you like and what you don't like. I think one of the biggest things is to differentiate whether you like bench research or you like clinical research. And that's a big difference. That's the biggest one that you'll see a difference in. And once you have an idea between those two things, then it's easier to pick topics within each thing. If that makes sense.
Thank you. The next question is, what was your favorite memory as a medical student?
My favorite memory. After my first day of rotation, there's nothing more amazing than realizing you're not stuck at a desk anymore. The first 2 years of medical school are very grueling. Like I said, it's a lot of studying. You're in a library or you're at a desk. You're sitting all the time. You're worried you're going to get clots in your legs because that's how much you're sitting and studying. And then you finally get into rotations, and that's when you feel like a real doctor. You're in a short white coat. You're seeing patients. You're, applying all this information you've shoved in your head for the last 2 years. And it is such a rewarding day when you see your first patient. It's a really nice feeling. Being a medical student, the first 2 years are the toughest years, especially the second year that you're taking step 1. Although now by the time you guys get there, it'll be pass fail. And I think so will step 2. So things are going to be changing in your future. But I think that definitely was my most memorable day. I took a picture that day, my white coat, so excited.
Awesome. What would you say are the main differences between working as a hospitalist or working in clinics or private practice? Yeah, and which do you prefer?
Yeah, so it's a big difference, and you'll, kind of decide based on your personality, I think, what you prefer. So hospitalists will work in the hospital, and their schedules are usually 12-hour days, 7 to 7. So they'll work 7 days on, 7 days off, 7 days on, 7 days off. And so you're in the hospital, it's very acute. You're usually seeing patients that are sick enough to have gotten admitted, and you're taking care of them in the hospital. There's different types of hospitalists. So there's, pediatric hospitalists, there's medicine hospitalists, there's GI hospitalists. So every specialty has its own hospitalist that's in the hospital and kind of works that schedule. And then in the outpatient setting, you're seeing routine patients that have various complaints that are non-urgent that are coming to you in the clinic. This is more of an 8 to 5 schedule. You work every day, Monday through Friday. So it really depends on what kind of lifestyle you're looking for. Most specialties, you'll have a mix of both, where you go into the hospital sometimes and you're in the clinic sometimes, or you do both, a little bit of both every day. So it really, there's hybrid mixes of that too. So it really depends on when you get there, what kind of patients you like to see. A lot of people, especially when they're younger, will lean towards hospitals because it's exciting. You're dealing with patients that are sick, and you're, providing them care and things like that. So there's a lot more activity and hustle and bustle, rather than in the clinic where it's more calm and you're seeing patient after patient. So it really depends on what you're looking for at that time. I'm going to be doing a mix of both. I'll be doing, I think, 10 weeks of inpatient. For me, it'll be all 7, Monday through Sunday, with call. So I'll be doing like 24s for 7 days and for those 10 weeks. And the rest of the time I am in the clinic or I'm scoping. So I'll do procedures as an outpatient. But I wanted a mix. I wanted to be in the hospital sometimes and not others. It can get very exhausting being a hospitalist because it is all go, go, go. You're constantly kind of on the run.
So we have a wonderful question. How do we handle the obesity epidemic in this country? What needs to be done to target youth eating healthy, nutritious foods to prevent them from becoming overweight, obese, and potentially developing diabetes?
Yeah, that's a really good question. It's a very complicated question too, because, there's so many aspects that go into obesity. It's not so simple as, I ate this much and now I'm obese. There's so many things that go into patients' weight, hormonal issues, of course, the dietary things that what we put into our mouth, lack of physical activity. But there's so many things that affect our food, right? A lot of obese populations don't have access to good food. They don't have access to grocery stores. There's a lot of food deserts where, patients don't have grocery stores for miles and they only have access to convenience stores, which don't have vegetables and fruits. So there has to be kind of a systemic food change. And I don't know, that's going to take a lot of time and a lot of fighting with large corporations and things like that, I think it's great for doctors to get involved because I think we need to help create that change because we see the effects of obesity more than anybody else. Policies have to change within these large corporations. Marketing has to change. We have to have nutrition labels, but we also have to educate patients. We have to educate them on how to read labels and understand what the labels mean because it's actually it can be very confusing to patients on what kind of nutrients they need and how to read a nutrition label and compare it to another product. Also money, things that are healthy are often a little bit more expensive. So, we have to change, again, that's a system thing rather than anything else. We have to guide patients towards, various grocery access. So there's a lot of programs now popping up and if you are at a hospital, you can request them to come to your hospital, but they will sell local produce at discounted rates for patients. And sometimes that's their only access to vegetables. Sorry, what was your question? The obesity epidemic. I started going on a tangent there, but in terms of handling it from our side, right now we have diet and exercise, which, I think that you'll find when you become a practitioner, you only have 10 minutes per patient, 10 to 15 minutes. And it's hard to address all of their medical issues and then to talk to them about how to change their nutrition. So you have to find a good registered dietitian to send patients to. You have to develop different kind of papers to give them to kind of educate them as quickly as you can in that small amount of time that you're allotted. If that doesn't work, then we have pharmacotherapy, so medications for weight loss. And that a lot of people aren't prescribing or utilizing. So that's something else that I think different physicians can kind of step up and start to prescribe those medications on patients that failed dietary and, exercise things. And then bariatric surgery. There's a lot of patients that we should be referring to surgery that we aren't. And endobariatrics, which is the GI interventions. So that's hopefully up and coming, and maybe more patients will be amenable to getting that done over surgery. So there are options out there. And I think that we're also not utilizing the options that we have currently. I hope I answered the question.
That was very interesting. Thank you. The next question is, what would you say is the most frustrating part of your job?
Most frustrating part. I would say accessing patients. I mean, with telemedicine right now, a lot of the time, so we cater to an inner city population, a lot of patients on Medicaid. We have a huge homeless population, and moving to telemedicine, it's really hard to contact homeless patients. because they don't have phones. A lot of these patients don't have cell phones. So that's been a huge issue right now, accessing patients, not being able to see patients and give them the best care, because I feel like I can't examine somebody's belly, or assess someone's confusion, or do rectal exams to see if they're bleeding and things like that. So I think right now that's been my frustration as a fellow. I'm sure when I become an attending, a bigger frustration is going to be billing, because that's what medicine kind of comes down to these days. And when people employ you, that's what they're looking at, and kind of shoving as many patients they can in your half day or full day. And that, I'm sure, will be very frustrating, but I haven't gotten there yet.
Definitely. Thank you. The next question was asked by a student. So, since Chadwick Boseman's death, there's been a lot of discussion about colon cancer screening in the Black population. Has there been a change in the way you approach Black patients, or how the department encourages colon cancer screenings?
Yes. So, even before Chadwick Boseman's death, we try to make sure that African-American patients over the age of 45 start their colon cancer screening. And then they're in a surveillance regimen after that. I think the harder part is getting patients to come to the initial visit to get their initial screening test. And I think a lot of it has to do with fear of getting tests done, fear of finding out that they might have cancer, patients waiting till the last minute because they don't have insurance. And so they don't wait till they wait till they have symptoms. So a lot of these things, there's a lot of barriers to patients coming in and getting their initial colonoscopy. So, I think that patients, since Chadwick Boseman's death, are more aware of how important it is to get screened. But I feel like we've kind of always been, if we can get a patient at any medicine clinic, any clinic at all, we try to get them screened. But now they're leaning towards screening everybody at 45. So not just African Americans, but all other people as well. It's interesting. I have had 2 patients now in their 30s who just came to me for rectal bleeding, very minimal, normal, everything else. And this was right after Chadwick Boseman's death. I sent both people to get colonoscopies, and both had colon cancer, and they were in their 30s. So it's definitely important not to ignore symptoms. If you see patients, and you'll see them, when you start rotating in med school, or you're, after that, when you're in clinic, if you see patients with weight loss and bleeding or anemia that's unexplained, send them to get a colonoscopy.
Thank you so much for this presentation. So to wrap up, do you have any final advice for our students?
Yeah, I would say the big thing is medicine is a long journey. It has a lot of ups and it has a few downs. There are going to be days that are really tough, emotionally, physically. So make sure that this is the field that you want to go into, and, opportunities like this where you are listening and able to talk to different physicians, or, once rotating in person opens up again, following them in their clinic, making sure that you really like the field that you're going into. It's so, so, so very important.
Awesome. Well, thank you so much. We really appreciate you taking the time out of your day to guide us on our journeys. And so for all of my students, please stick around. I'm going to be going over how to get your verified hours for joining us today at the end of my presentation. And so really quickly, I just want to remind you all, take some time to reflect on the session that happened today. What inspired you to join us? Why are you here? Why are you going into medicine? Were there any parts of today's sessions that particularly resonated with you? And what are some key takeaways that you are going to take from today's talk and utilize in your life in the future? So this, you do not have to turn in. This isn't a requirement or anything. This is solely for your purposes. Many of you will be applying to various health programs in the near future. And so this will really help with your application process, talking about your activities, as well as maybe even your personal statement. So just keep that in mind. If you would like to get published and that's something that you're interested in, you can actually submit reflections to our website, and our editor-in-chief will contact you with more information regarding that. So like I was saying, on our website, you can submit any articles, reflections, reviews, or success stories to get posted and get published on our website. And so if you are interested in that, I recommend checking it out. We do have a rubric that will be made available. So if you are unsure the expectations, go ahead and email us and we can just shoot you a PDF of that rubric before it gets put out onto our website. Another quick reminder is that we do have our mentorship opportunity. So if you're interested in potentially meeting mentors, you should be sure to join us. And so the way to get an invitation, this is by invite only. And so the way to secure your invitation is by filling up your bingo board. So this is an opportunity that we're making completely free for students in order to give everybody this accessible opportunity to get a mentor. And so what you have to do is post this bingo board on your social media and have various donors, which would be your followers, contribute to your success. And so ultimately, we're trying to raise money to keep pre-health shadowing free for students everywhere so that this opportunity can be made available to anyone who is interested. It's pretty quick. All you have to do is post it. Once your donors send in their donation, ask them for a screenshot so you can see how much money they donated so you can block out the square, as well as, maybe send them a little thank you note. And so if you guys are interested in this, you can find our Google Drive folder and download the 3 posts to put on your social media. If you can fill up your whole board, you're going to submit it to Pre-Health Shadowing and you will receive an invitation to our mentorship networking event. If you are interested in joining our student team, we are taking applications. Pre-Health Shadowing is a student-based, student-led nonprofit organization with students all over the United States and even the world. And so if you're interested in meeting with like-minded students, gaining professional experience, as well as leadership experience, be sure to apply and submit an application. We understand that you guys are all pre-health students and don't have all the time in the world. So if you're still looking to try to get involved but need a little bit more flexibility, you can sign up to be a volunteer and work from home on your own time for as many or as few hours as you're able to. So if the only time you have is at 3 in the morning, you're more than welcome to help us out at that time. We do a lot of outreach and a lot of content production. So if you're interested, be sure to register for a volunteer. Some new exciting things for our volunteers: we are starting projects. So this gives anyone the opportunity to lead a team of students in an amazing initiative. We are taking project proposals from our volunteers. So if you're interested in starting your own project with pre-health shadowing and being the leader, be sure to sign up as a volunteer and get on our onboarding roster. This is an opportunity for you not to donate, but actually to share our GoFundMe. This is, we rely on support from our community. We are just a bunch of students putting this together. And so, all of the money that it takes to pay for the Zoom, to pay for the website, for our booking, our Calendly, our mailing system, it's really adding up. And we ultimately want to keep this program free for everybody. So I'm humbly asking you to please share this link if you joined us today with 10 people. If you share this GoFundMe link, you can actually get volunteering hours, certified volunteering hours. And so please share it. You can share it on your social media. You can email it to folks. We really appreciate any way that you guys can help us get the word out. Be sure to tag us on all of your social media posts involving pre-health shadowing at pre-health shadowing, and use the hashtag pre-health shadowing to have the opportunity to get reposted on our official pre-health shadowing account. We are active on TikTok, Instagram, Facebook, Twitter, YouTube, you name it, we're there. Oh, and LinkedIn. You can find us on LinkedIn also. Alrighty, so for the mentorship opportunity, I went over that already. There's just a little reminder for you all. Our upcoming shadowing sessions, we have a shadowing session tomorrow with Dr. Todd Hanna. And then on January 11th, we have a shadowing session with Dr. Jeremy Grossman. So be sure to register for those. Today, we actually found out that our Zoom capacity is only 300. So we did have over 1,000 students signed up with us today. And so we will be looking into upgrading our Zoom. This will be lots and lots of money. So please help us out by contributing. Please post your bingo boards. Really, anything helps. We are trying to keep this program alive, and so we really need all the help we can get. We're relying on you guys. So last but not least, to get your certificate that verifies your your virtual shadowing hours today, you are going to go to the website, www.prehealthshadowing.com, and you are going to find our speakers page today. Once you find Dr. Shah's page, you are going to do free Take This course. You will have 30 minutes and 2 tries to complete the post-shadowing assessment. Once you complete any passing score, you are eligible to receive your certificate. I recommend that if you get a passing score, even if it's not the score you wanted, if you pass with a 70%, nobody's gonna know that you passed with a 70 and not a 100. So I recommend, once you met that threshold, take it, you get your certificate. If you happen to get a 70% the first time and then you fail it the second time, your eligibility for that certificate goes away. So please make sure that, the second you get it, just grab it and go. You must click Finish Course in order to get your certificate. So if you have taken the post-shadowing assessment and you passed it and your certificate's not there yet, you got to go back and hit Finish Course. So feel free to reach out to us if you have any questions. The certificate can be downloaded immediately once you click Finish Course, and it can always be found in your profile under the Certificates tab. If you guys have any questions, feel free to reach out to us at info@prehealthshadowing.com, and we look forward to seeing you at our session tomorrow. Thank you all, and have a wonderful night.